We are live.
Dr. Vaidya, please share your slide.
Yes, sir. Yes, sir. Are my slides visible, sir?
Yeah.
Yeah.
You can
Good
start now.
evening, everyone. I welcome one and all for yet another iFocus online session. Presently, we are in the 22nd Cataract module, and this is the 408th episode of iFocus online session. Today, we have Dr. Paresh Vaidya, sir, who is a senior consultant at Center for Sight, Surat, as a speaker. And the topic for today is phacoemulsification in small pupils, as in undilated or poorly dilating pupils. The speaker, we have Dr. Amit Pandey, sir, as a moderator for today's session. He has various accomplishments. Sorry, just a minute. Just a minute, I'm sorry. Yeah. So Dr. Amit Pandey, sir, he's a moderator for today's session. He has various accomplishments to add on to his list.
Can you share the screen, please?
He's the first surgeon to implant an iStent inject. He's the first surgeon in Gujarat to do a Ahmad clear path and perform excisional goniotomy. He has multiple publications and numerous presentations in prestigious national and international journals and conferences. So over to you, Dr. Amit sir, for the introduction of our esteemed chairperson, Dr. Professor Kamaljeet Singh sir, and the speaker for today's session.
Could you go into slideshow, please, for the full screen? Yeah, thank you. Good evening, everyone, and welcome to iFocus Online. Again, it gives me an immense amount of pleasure, and it's an honor for me to introduce the chairperson for today, Kamaljeet Singh sir. Sir has graciously agreed to again chair this session. Sir has done his MBBS and MS from MLN Medical College in Prayagraj, and he has been the HOD of that medical college as well. He was a past president of IRSI UPSOS and has served as an editor in various prestigious journals. Currently, sir is the head of department at United Institute of Medical Sciences and a senior consultant at Center for Sight, Prayagraj. He is the chief editor of Ophthalmology and Allied Sciences and has been awarded the WHO Fellowship in Medical Retina from USA and fellowships from Wills Eye Hospital, Philadelphia and Massachusetts, Eye and Ear Infirmary in Boston. Sir has published many books in ophthalmology, the most popular being Small Incision Cataract Surgery. He's an academician par excellence and a guest speaker of international repute, and we are lucky to have him again today here for this iFocus session. Thank you, sir, for giving your time.
Thank you.
Next slide, please. Dr. Kritika, can you change the slide, please?
Yes, sir. Sir, just find. Yes, sir.
Yeah, I'm very, very happy to introduce the speaker for today. I've been working with Dr. Paresh Vaidya sir for the last 8.5 years, and he's been a friend and a guide for me. And wherever I am, a lot of it has to do with Paresh sir. So it's I'm honored to introduce him today. Sir has done his MBBS, DO, and MS from Government Medical College, Surat. Sir currently is a senior consultant at Center for Sight in Surat, and he has experience of more than 25 years in anterior segment surgery, and he served as a medical director at South Gujarat at Center for Sight group of eye hospitals, and president of Surat Medical Consultants Association. Also, he has served as the president of Rotary Club of Surat West. He has a vast experience in phaco and femtocataract surgeries, refractive surgeries, and he has done a lot of charitable work as well, over 4,000 free cataract surgeries. and he's an excellent surgeon. He performs premium IOLs day in and day out. He has delivered many talks and lectures at different national and international conferences and conducted various workshops as well. Sir has received a mentor award multiple times, and he has recently received the gold medal at IRSI conference in Delhi. So thank you, sir, for giving your time to this iFocus online, and with our chairperson's permission, I would ask you to start the session for today.
Yes, please go ahead.
Thank you, sir.
That's great to see Dr. Vaidya here.
Thank you very much, sir. Thank you, sir.
Yeah.
Thank you, sir. Can you see my slides?
Yes, sir.
अमित स्क्रीन अभी नहीं है?
हाँ सर, स्क्रीन दिख रही है, स्लाइड चेंज नहीं हो रहा है. The arrow keys you can ये arrow key है ना सर, top sorry bottom left corner पे. So I think you can change the slide.
I cannot see the slides now.
अच्छा, have you shared your whole screen or just the PowerPoint presentation, sir?
I have share it.
And you can click on the screen and scroll the button down. And स्क्रीन पे क्लिक करके नीचे का आप नीचे स्क्रॉल कर लीजिए.
स्क्रीन पे क्लिक किया है.
नीचे का एरो दबा दीजिए. वो आप स्लाइड ऊपर नीचे एक बार मूव कर लीजिएगा जैसे नॉर्मल करते हैं. Any issues, Dr. Vaidya?
Yeah, I can't share the screen.
Okay, I'm stopping it. Just a sec. Just
stop it.
reshare it. Just reshare it and just click on the screen and scroll the arrows up and down. You should be able to move the screen. एक बार दोबारा reshare कर लीजिएगा.
आ गया?
हाँ जी, एक बार एरो से ऊपर नीचे कर लीजिएगा एक बार.
Yeah, okay.
First class. Perfect, sir. Thank you, sir.
Okay. Right. So, good evening, all. And first of all, I'm very much thankful to Dr. Mahipal sir and Dr. Santosh Honavar sir, and also all team iFocus for giving me this opportunity so that I can present my views and ideas and also my experience regarding this particular topic. As this is a topic on a very interesting topic, especially for all the ophthalmologists also and all the those coming postgraduate students and all. Thank you very much, sir, Kamaljeet Singh sir, for here as a chairperson to this talk. Thank you, sir. This is a tissue for which we are talking today. And I think so this is the most delicate tissue after the posterior capsule, for which we should have a respect. I think so if we respect this tissue, then this tissue will respect us, because handling of this tissue is very important. First of all, when you try to remove the cataract. So before going for the some of the surgeries and some of the pre-operative and post-intraoperative things, we should know the anatomy of the iris. So these are some of the muscles in the iris stroma. Two types of the muscles are there: sphincter pupillae and dilator pupillae are muscles. Sphincter pupillae, it is a muscle in a circular muscle which is a 0.75 to 1 millimeter wide, which is composed of a smooth muscle cells, and the muscle is 0.1 to 1.75 1 millimeter in thickness. This muscle, it encircles the pupil and it is in the pupillary zone. So it is composed of a spindle-shaped cells that are oriented parallel to the pupil. So contraction of this sphincter, it causes the pupil to constrict. And this is innervated by the parasympathetic nervous system. While the dilator pupillae, as you can see here, this is a muscle which is extending from the iris root, and it is going to the stroma below the midpoint of the sphincter. It is a dense band of a connective tissue which separates both the muscles. However, near the termination of the dilator muscle, small projections inert into the sphincter. So because of this radial arrangement of the fibers, contraction of this dilator muscle, it pulls the pupillary portion towards the root, thereby enlarging the pupil size. And this is sympathetically innervated muscle. Now we are going to the physiology of a pupillary dilatation and constriction. This is not much of importance to this topic, but since we know pupillary reactions of direct and consensual, and as we had a talk that sympathetic and parasympathetic nervous systems are there. The parasympathetic, it is a cholinergic effect, while the sympathetic, it is a adrenergic effect. Well, why we should know? Because there are some of the drugs which are responsible for the pupillary constrictions, as well as and some of the systems which are also affecting the nervous system, and that nervous system effects are also responsible for the pupillary constriction, which does not allow us to full dilatation of the pupil. And here you can see when there is a parasympathetic cholinergic effect, the pupil gets constricted, and sympathetic effect gives a pupil dilatation. So how we make a diagnosis that this is a small pupil, or this is a fully dilated pupil, or this is a mid-dilated pupil. And here we come to know that what is the pupil size, which we call as a normal, small, or a very small pupil. So normal is a pupillary size which is more than 6 millimeter, and small is a pupillary size which is 4 to 6 millimeter, and very small is a less than 4 millimeter size of a pupil. But this pupillary size is considered only when we dilate this pupil with our dilating agents like tropicamide plus solutions. And when we put these drops for a particular time, say for example, for the practical point of view, when patient has been put for the dilating drops in our OPD, and at the interval of a 10-minute time, when one drop of all this dilating solution has been put in patient's eye, at 10 minutes interval for at least 3 to 4 times. So say for example, at least 40 minutes or 40 to 45 minutes when these dilating drops are put. And after this, when the pupil is examined, and if the pupils are showing this type of a picture, and when you measure this pupil on a slit lamp, or when you see this pupil on a slit lamp, then you can put a diagnosis that these pupils are of a normal, small, or a very small category. So when we see a pupil on a slit lamp examination, or just by sometimes when we see on a torch examination, then we should have in our mind, we should know that what are the different causes of a small pupil. So here we divide our causes of small pupil into ocular causes and some of the systemic causes, as well as some of the causes which are related to drugs which patients are taking normally for a very long period of time. So these are some of the causes of a smaller pupil. One of the very most common cause is a pseudoexfoliation. And here the most common etiology is that tissue hypoxia, it leads to the atrophy of a sphincter pupillae and dilator muscles. And that's why there is a reduction in the stromal elasticity by accumulation of a pseudoexfoliation material. So now, whenever we see all this patients with a pseudoexfoliation syndrome, you will see a very fine whitish material deposited at the sphincter of a sphincter of the iris, and also you can see that this material is deposited over the anterior capsule. And sometimes these patients, they may have a phacodonesis also, because of these patients have a very commonly zonulolysis, sorry. And so this is a very common cause for a small pupil. Diabetes mellitus, very common cause. And here glycogen deposition in the iris, which causes a smaller resting pupil. Loss of sympathetic tone due to the diabetic neuropathy. And there is a weaker response to the sympathomimetic drugs. So very long-standing diabetes causes a very weak response to all these dilating drops. And these are some of the very rigid pupils which doesn't dilate with the drops. Causes of small pupil, there may be a trauma like pupil irregularities are there. Very long-standing inflammation, hyphema, and increased intraocular pressure and zonular dehiscence, they are associated with the small pupil post-trauma. Uveitis, very common cause, as we know that ring posterior synechias and iris atrophy, which is associated with this disease. There is an increased risk of cystoid macular edema with this disease condition, and pre-treatment with steroid is necessary. So in all these types of the disease, we have to take care. Pre-operative examination as well as the pre-operative medications has to be given in all these patients. Very cautious examination on slit lamp, and perfect planning intraoperative is very much necessary. Mature and hypermature cataracts are very common because they are normally seen in very elderly patients. And these elderly patients, they may have an atonic pupil also sometimes. And their dilator atrophy is a very common cause. And this may cause a small pupil. Some of the surgical causes of small pupil. So if there is a previous intraocular surgery like pars plana vitrectomy or a trabeculectomy has been done, then it may cause a small pupil in all these patients. Duration of surgery. As we were talking about that some of the ocular clause in the intraoperative time. So whenever there is a prolonged surgical time, then there is a release of a natural prostaglandins, and this, it will give progressive meiosis to the iris, and there will be a constriction of the pupil during the surgery. Very nowadays, as we use femtosecond laser treatment very commonly, but in most of the 30% of the flex cases, we have seen that there will be a constriction of the pupil after doing a femto laser. And this laser creation of the anterior capsulotomy is mostly a primer trigger for increased prostaglandin release, and which may lead to the meiosis. So these were some of the ocular causes which were leading to small pupil. But now this is the most common and cause which we come across. If we don't ask for the particular history to the patient, then sometimes we'll end up in a very massive problem intraoperatively. So a perfect history taking in male patients especially, has to be done, whether patient has any disorder of a prostate or not, and patient is taking this group of a drug or not. because whenever the patient is taking tamsulosin group of a drug like Unimax or Unimax D, then there are maximum chances that patient may develop this intraoperative floppy iris syndrome. It's a triad of signs that can occur during the cataract surgery. Normally, when you see all these patients, they may have a pupillary constriction or their pupil may not dilate completely. But sometimes in these patients, there will be a full dilatation of the pupil. But as soon as you enter inside the eye, this iris billowing, iris prolapse, and progressive intraoperative meiosis is very common. Associated with systemic administration of tamsulosin and other alpha-1 adrenergic receptor antagonists like alfuzosin, doxazoxin, and terazosin. So the correlation with the duration of the use of these agents and the incidence of pupillary meiosis, this IFIS is weak. Therefore, even if a patient has a remote history of tamsulosin use, with a rapid decontinuation, the surgeon should go into the surgery prepared for IFIS. So normally in all these cases, whatever maybe the duration patient is taking this drug or not, after taking a perfect history, I think this drug has to be discontinued for at least 1 week to 15 days before you go for the surgery, because effect of this drug remains inside the body and it may cause this syndrome, even though if the patient is discontinued this drug. Rarely these medicines are also prescribed for hypertension and urinary retention in women. So a thorough medical history should be elicited in all these patients. Medical causes of small pupil. Whenever these topical glaucoma medications are given, which is very commonly used, is pilocarpine. Pilocarpine and other cholinergic stimulating agents like carbachol, and these anticholinesterase blocking drugs like dimecarium and ecothiopate, neostigmine and physostigmine, which is now very rarely used, are the causes main leads to a small pupil. You can see here that some of the drugs which are normally used and normally prescribed by our friends, medical practitioners, has to be taken care. And we have to ask for the particular history of drugs whether the patient is taking or not. Like as I told before, that alpha-adrenergic antagonist drugs, all the tamsulosin group of drugs, as well as other drugs. Like especially if I say antipsychotic drugs like risperidone or haloperidol, as well as some of the cholinergics like acetylcholine, some of the imidazoline group of drugs, some chemotherapy drugs, or this, as when we talk about like opioids also. So these are some of the drugs which history has to be elicited before we come to the conclusion. Some of the other causes of small pupil: Addis tonic pupil syndrome, Argyll-Robertson pupil, Marcus-Gunn pupil, Perinaut syndrome, glaucoma, as we know, Horner syndrome, sometimes central nervous system when it is affected by intracranial hemorrhages, especially when that hemorrhage is in the pons area, hereditary disorders, cluster headaches with ptosis, iridocyclitis, and fatal familial insomnia. So if we do not take care of this small pupil preoperatively, and if we do not plan our intraoperative surgery steps, then what can be the complications are associated with this? Because whenever you plan your surgery with the small pupil, your first aim, it should be that there should be a good visualization, and you should get a very good red glow. But whenever the pupil gets constricted, you lose that red glow, and that's why there will be all great chances of capsular tear and vitreous loss. So mostly about these two are a very common complications which occurs. So that's why there will be an improper IOL implant implantation, and sometimes it may lead to retained lens fragments, because these lens fragments, they are hiding below the iris, and sometimes you will not be able to see that lens fragments, or some cortex materials, they remain below the iris, and that's why it will lead to that fragments or lens materials remains, and that will lead to the postoperative inflammations. Sometimes postoperative iritis lead to cystoid macular edema, and so these complications are associated. Postoperative ocular hypertension, as well as if you don't see the good transillumination, may lead to iris damage. Permanent sphincter tear and mydriatic pupil may also occur, because if you catch hold that sphincter pupillae, then there will be a tear to that sphincter. So whenever you go for the surgery, perfect calculation, perfect management, preoperative preparation, and as well as what type of a drug you want to use, what type of the instruments you want to use inside operation theater, that all preparation has to be done by a surgeon, so that at each particular step, you will be able to handle, if any complication occurs. Preparation mostly in the early stages, if you are not confident, then always go with a periverbal anesthesia. Never try topical anesthesia in the initial cases. Once you become very confident, then you can go. You should have a microrhexis forceps and scissors with you, so you can handle from a side port. Also, you can handle rhexis from the side port. You should have a backup of a 3-piece or a PMMA IOL, so that in case of a vitreous, this PC tear or vitreous loss, you can put this IOLs in a sulcus. You should have a standby VR surgeon if sometimes these fragments, they go into the vitreous cavity or they fall down onto the retina, then that cases can be handled well by the surgeon. In an eye on a meiotic therapy, discontinue for a week. In shallow anterior chamber, preoperative mannitol should be given. The diaper should be given to the patient, because the surgery time is going to be prolonged, and at that time, patient should be not in a discomfort. Being prepared and having the patient on the same page, it will calm the surgeon's nerves as well. So the main part of this phacoemulsification in a small pupil is patience, because you should take a time at each and every particular step, and it will give the good results. Management preoperatively, what is the best best way to do it preoperatively? Topical tropicamide 1%, phenylephrine 2.5%. It should be given 1 hourly before the surgery, every 15 minutes for 2 to 3 times. Cardiovascular side effects of phenylephrine, they should be kept in mind. Sometimes it has been said that topical NSAIDs like flubiprafene 0.03% or ketorolac 0.5% or bromfenac 0.1%, it gives a sustained pupillary dilatation. So it may be given 1 or 3 days before surgery. So it gives a inhibiting cyclooxygenase that effectively block the metabolism of arachidonic acid into prostaglandins. Thus, it reduces the release and subsequently adverse effects on pupillary dilatation. This is how do we go for the management intraoperatively. Nowadays, we use this all since long time, middrain, which is an intracameral middrain, tropicamide 0.02% with phenylephrine 0.31 and lidocaine 1%. And this is used intracameral, which gives a very excellent pupillary dilatation. And this has a very potent effect. So it's a fast-acting drug, and it have a very sustained dilatation throughout the surgery. Better patient and surgeon comfort with middrain, it has been noted. Intracameral mydriatic use, it can assist with a rapid pupil dilatation. So it is also advisable, which is after femtosecond also you can use it. Sometimes disadvantage is that slower rate of pupillary dilation. Isolated incidences of endophthalmitis and TAS, it has been noted. So here is my video. I can show you. This is a small pupil phacoemulsification. As you can see now, this is my case that here it is a quite mid-dilated pupil. So I approached this case without any particular instrumentation or without any assistance for the pupillary dilatation. So as you can see that as I progress with my rhexis, the pupil is quite perfect, good dilated. I started the rhexis, and it is a good, quite enough rhexis, a good large rhexis in which I can perform my phacoemulsification. This patient, perfect preoperative history has been taken. Everything is good and fine. Nothing was contraindicated. So I was also quite good with the surgery that nothing is going to happen. But as now I am handling the case, you can see that just now the pupil is quite dilated. And now I have started the phaco surgery. Though I have not touched the iris. So pupil has started now becoming small. And cataract is about nuclear grade 2 to 3. And I'm doing a phacoemulsification. You can see just in the center, because I'm worried that if my probe goes into the periphery up to the margin of a pupil, then it may catch hold that iris tissue. So I'm separating the, sorry. Each and every step, I'm putting a viscoelastic substance. Here, in this case, you can use a higher viscoelastic substance also. Sometimes you have to use your Sinskey hook or some of the instruments by which you can rotate the nucleus. Your phaco parameters also you can use according to your comfortability. That now you can see. Every time I remove the phaco probe, the pupil becomes smaller and smaller. So every time I have to put a viscoelastic substance, and at each and every stage, I took a Sinskey hook, I particularly move the nucleus, put it in a particular position, because at the 6 o'clock position where I'm from the starting and at the just opposite to that end, I have to put that nuclear piece over there, because I cannot catch hold that piece from here or here, because it will be very tricky for me, and the pupil is becoming small, so it will be difficult, and iris may come in my probe. Now you can see the size of a pupil. It has become very small. Just now I put I have tried, and just now I put a phenocane material, the substance, but then still the pupil is not dilating. Now, as I have come for the cortex part, now you can see that once I put a fluid, the pupil get dilated. So here I turn my microscope into the coaxial illumination part. Here I can see that cortex material easily, much, but you can see that I'm still not been able to remove the cortex material because it is below the iris margin, and for me also it is difficult. I'm catch holding the this pupillary margin. So I put again viscoelastic. Again, I go to the periphery just and try to catch hold that tissue, but still not possible for me. So here you can see that some of the cortex material is still remaining, and pupil being more constricted more and more. Because I have touched the iris, that's why it is becoming more constricted. So each and every step I am putting viscoelastic so that iris can become. Now here, I thought that I can use I have put a viscoelastic. Now I am just using only dry aspiration. So in left hand, I have a Sinskey hook. I'm just removing this cortex material. I'm seeing much better by stretching the iris and having a good look of iris. Cortex is removed actually, but now you can see the size of pupil. From my left hand, I'm putting viscomet so that anterior chamber is more filled, the bag is more filled with the viscoelastic substance. I cannot see that how I will put a trailing haptic. So I dip down the leading haptic into the bag, and I see that it goes inside the bag, and then I dip down the trailing haptic. So, but now we have all these intraoperative management systems are there. So mechanical enlargement of the pupil is very, very much now available, and very good iris hooks are available. These are the disposable material iris hooks are there. They are inserted through very small paracentesis, which has been done. 4 to 5 hooks are usually used to enlarge the pupil. Oting and Omfroy, they describe this diamond-shaped configuration. You can see over here that when you put this hooks, there will be a diamond-shaped configuration of this iris, this pupil becomes. Paracentesis, it should be made peripherally to allow insertion of the hooks at iris plane. If it is too anterior, tenting can occur and it can damage the iris. This is very, very important. Capsule hooks can also be used in case of a zonular weakness. So along with the iris hook, you can use a capsule hook also if there is a zonular dehiscence. These are the intraoperative management of a mechanical stretching. These are used for stiff and fibrotic pupil. Where there's a pupil margins are very fibrotic, then you can use this stretching. Some of the instruments like Y hook, then Sinskey hook, and some of the Kuglan hook is there, and Lester hook. But combination of this Lester hook with a Y hook, it goes good to enlarge the pupil. Stretch with the two instruments placed 180 degrees opposite to each other at pupil margin and slowly put apart until the angles is reached. It can be repeated in opposite directions as well. This creates a micro sphincterotomies. Stretching the pupil might be more traumatic to the iris sphincter than using a ring. Also does not maintain the mechanical control of the pupil. So it's a somewhat. So here is my video on actually, I will show you just the hooks, how I have put it. This is a dense brown, more or less about grade 4 cataract. And I have just stained it because I am not seeing the, so here you can see the mechanical stretching. This is one, this is one, this is 2. So this how the mechanical stretching has been done. Still, I'm not confident. So because of the cataract is very hard. So you can see how I am doing this putting incisions for iris hooks. Here you can see that my incision is over here. My side port is here. One side port is here, and one side port is here. So the positioning of iris hooks are very important, because it should be not at the plane of a cornea, it should be at the plane of an iris. Because if it is a plane at the cornea, then there will be a tenting of the iris, and it will hamper with the entering of the probe and other instruments. So whenever it is at the level of iris, then there will be a proper enlargement of the pupil, and it will give a good exposure of the cataract. Here, these are the iris hooks which has been put. While putting the iris hooks, you should have a proper viscoelastic substance in anterior chamber, so that it does not damage the anterior capsule or so. It mostly does not, but you should have a proper space to put these hooks. Here you can see the perfect square which has been made, so that you can have a good rhexis. You can do it. Higher viscoelastic substance like Hilon GV it can be used in all these cases where there is a very dense brown cataract or hard cataracts. And along with that, if the pupil is very small, you can use this higher viscoelastic substance, which protects corneal endothelium also, and it helps in the cataract surgery. Here I have done a divide and conquer technique because the cataract was very hard, and I don't want to do this chop and stop or any other technique. So I did a divide and conquer technique. So here you can see that iris is perfectly stretched, and now I am removing the cortex. Now how this iris hooks are removed. Intraoperative management, there is a very nice pupillary expansion rings are available. This is a Malugin ring, which is made up of a polypropylene designed with the 4 scrolls with the interconnections, and then run anterior to posterior between scrolls. The original ring is made of 4. Now this we are available is a 5. 20 is more flexible. Sizes are available in 6.25 and 7 millimeter. Just a small video, you can see it. How it is applied, Malugin ring. It goes through a 2 millimeter incision. So anterior chamber is very well maintained. You will have a very good exposure of the cataract. There is a very well dilated pupil. This is an instrument which is used. Now it has been retracted. And then once it is retracted from here also, the opposite end, it comes out in the same manner like what in the previous way, when just comes out very easily. This is a BHEX ring which is available. It's a BHEX pupillary dilatation, which is a Bhattacharya ring. Here you can see that really a small pupil is there. Cataract is also about grade 3 cataract is there. And a very small, very fine ring is available. Why it is called a BHEX? Because it dilates the pupil in a hexagonal shape. And just from the side port, you can see that it has been tucked on the sphincter pupillae and pupillary margin. And you can see that hexagonal shape of a pupil. You will have a good exposure to the do capsulotomy, rhexis, and then you can perform the cataract surgery easily. So these are some of the instruments which are available. Other uncommon devices available like Visitec eye ring pupil expander, 5S eye ring, iris ring, perfect pupil, and Grether expander and Clark's ring. Postoperative management. Patients with small pupils are at a high risk of delayed healing, corneal edema, uveitis, CME, elevated IOP, and vitreous loss and retained lens material. As a result, based on the severity of the risk, the surgeon might consider extending the postoperative course of anti-inflammatory treatment. Preoperative discussion opens up the door to educating the patient about the possibility of delayed visual recovery, as well as potential need for the frequent or a prolonged eye drop treatment, even sometimes subconjunctival or subtenon injections in a very rare situations. So here I come to the conclusion of this topic, that management of a patients with small pupils begins preoperatively with the identification of risk factors, patient's counseling, surgical planning, and the use of a preoperative anesthetics. If continues during the surgical process through the use of intracameral dilating and anesthetic agents and mechanical dilating techniques. Finally, postoperative management, it might be customized in certain cases with the alteration of a postoperative eye drop regimens. But the precaution is always required. So I think so preoperative evaluation is very much important. Thank you very much for giving me this opportunity. Thank you very much, sir. Kamaljeet Singh, sir. Thank you very much.
Thank you, sir. Thank you for that very informative lecture, as well as really good videos as well. Kamaljeet, sir, your comments, and would like to know your preferred way of handling these small pupil in phacoemulsification.
Thank you, Dr. Amit. It's a wonderful talk. Almost everything has been discussed. I just wanted to say that after preoperative examination, patient should be put on steroids.
Your voice is breaking, sir.
What I'm saying is that the patient should be put on topical steroids for 3 days time. And I would prefer doing the surgery under local anesthesia, because many times you need to put iris as rest mode, and you might require a longer time. So you should be comfortable if a cerebral block is there. And post-operatively, you must give steroids. Psychophysics are also good. And a small RDP would always help. That is where you have fibrotic lumbar. I have done some cases where you have a fibrotic, then you have lots of synapse that way. Many a time I find that if you break the synapse, the people start dilating.
Right.
So this goes. Find the people dilates. Helps in surgery. The important thing is that when you are using your phacoemulsification, then the help of dialer or any hook, keep on pushing the iris towards the pupil. That can be done in case the pupil constricts our eyes. So what you can keep on doing is that you can simply keep on pushing the eyes on the periphery and keep your phaco handpiece in the center. Do not go and follow the cortical pattern on this. That is very, very important. And all these small points, right? And, Dr. Vaidya has covered almost everything, and I don't need to say anything more. And there are questions to ask. Thank you.
Thank you, sir. Yeah, we had discussed that point in the previous iFocus as well. If we have a iris that is prolapsing again and again, making a small PI on the prolapse part really helps, especially if it is bulging out and that post.
What I was saying is that if the surgery goes normally, still if you do after putting the implant, you should do a small RP because many times you have reaction post-operatively.
So that can lead to Seineke formation and anguloclosure glaucoma. Yes.
Yeah, but one thing I, Dr. Amit and sir, one thing I forgot to tell you that nowadays when we are putting this high value lenses like multifocals and trifocal lenses, all the surgeons or those we should be also very cautious when we are using these all pupil expanders, those who are damaging the sphincters, because in sometimes the cases when there is a post-operative this stretching of the pupil or by putting a hooks also, if the pupil remains semi-dilated and patient has a trifocal or a multifocal lens, then these all patients, they have a complaint of glare and halos because of the excessive light enters inside their eye and the pupil is not reacting. So that are also to be kept in the mind when they are going for the this multifocals and trifocals.
Sir, I would like to know your opinion on sphincterotomies, Kamaljeet sir. If we used to do it, cuts on the sphincter.
Multiple.
You prefer doing that now or stretching of the iris, the pupil works in a simpler and a better way? You can't hear you.
I can do sphincterotomy also in these cases. If after the stretching of the pupil, you find that pupil is not done. So a small sphincterotomy at 6 o'clock, 9 o'clock, and 3 o'clock to give you enough space to complete your Phacoemulsification.
Right, sir. Do you use these instruments, these pupil expanders frequently, sir? BX ring or the iris hooks?
I have used the BX rings.
Mm-hmm.
If the pupil is not very chronic, then BX is very good. Otherwise, again, our patients cannot afford, so I have not.
I think it's not very costly, 1,500 rupees or so. I think that's the.
Yeah, BX is good, yes.
Yeah, that way, Make in India works.
Myelogin is very costly, actually.
Yeah, Myelogin definitely is costly. So, any preference in a certain case that you would use a BHEX iris hooks? What I do is if it is associated with a floppy iris, I prefer putting in the BHEX. Now I've almost shifted to using BHEX instead of the iris hooks, mainly because no other ports have to be made. Already
That's very good. Yeah, that's
Yeah, already these cases are complicated. They have shallow ACs as well in many cases, and making 4 more ports, leaking ports, that would that really complicates the case even further sometimes.
I found that if you just if there is a fight,
Right, sir.
try to remove it. Comes out, you find that you put dilate. But in that case, you don't need that.
Right. One more point I wanted to make in floppy iris was the modified soft shell technique. It really works, putting in the viscodispersive substance first, and then in the center making a space with the viscocohesive, and that really works with IFIS and small pupils as well. Another point I wanted to make for the young surgeons is. Initially, when I used to do, I started doing phacos I used to get frightened seeing a 5 ml pupil or even a 6 ml pupil. I would feel that it's a small pupil. But believe it or not, you have been, if you are doing a phacoemulsification routinely, you have been trained in doing a small pupil phaco, because we work only in the area of the rexus. So your rexus is usually 4.55 mm, and we operate in the limits of the rexus. So we have been trained, if you're doing a phaco routinely, we are trained in doing a small pupil phaco, small being 5 or 6 mm. So it's just a matter of making a good rexus, taking the margin of the pupil as a guide. And yeah, like Sir showed in his video, the rexus should not go behind the iris. That's something that we need to take care. And don't think too much about it. Yeah, keep yourself prepared. You should have the iris hooks or the BHEX along with you whenever needed. That should be applied. The sequence of iris hooks is something I wanted to throw some light on. When we apply one hook, I think the next step should be the opposite end of the iris, and similarly, so 4 in a crisscross manner. And don't pull, like Sir showed in his video, and Kamalji Sir also told, don't pull the iris hooks, the iris too much with the hook, or else it will cause intraotomies, and the next day you'll land up with a mid-dilated pupil. You'll cause permanent damage. So
Then the chamber becomes very shallow. Then the chamber becomes very shallow, and when you enter with the
probe, it may cause it.
Yeah,
It becomes difficult.
yeah, the iris starts coming in.
Very important part is that when you are entering from the incision and the iris hooks which are apart, just on the one side and just on the other side, just see to this, that when you are entering with the phaco probe, see that iris is not coming, because otherwise you will do a iridodialysis, because that iris is upwards.
Engage the iris.
Against the iris. And iris is upwards. So that's
and the main incision that I feel is slightly longer in the case of small.
That's another important point.
From the normal.
Right. Dr. Krutika, do we have any questions on the online platforms? I think we have a question here, which is better, Malugin ring or iris hooks to retract the iris for better exposure in surgery? And does the grade of the cataract changes the type of expander that we use during the surgery?
Sir?
Kamaljit sir, do you want to take that question?
See, as we have already discussed, iris hooks is best to avoid.
I think the difference between Malugin and it's costly in India. So
costly in India.
If you consider
yes, in case I need to dilate it. And in a chronic people, I would use a iris hook where the people does not retract even with the because it is slightly softer. There I would this iris hook. Otherwise, BHEX is.
BHEX is.
If we compare BHEX with the iris hooks, the biggest advantage that we have with the BHEX is it goes through the main port, and you do not have to make another port for it, and it comes out also very easily with from the main port itself, like was shown in the video. So and it pulls, it keeps on all 6 sides, it keeps the margin of the pupil in control. So if it's a floppy iris, like Sir told, BHEX would be a better choice. Dr. Krutika, do we have any other questions on the online platforms?
Yes, sir, I can see there is one question.
Your voice is not coming.
Am I audible, sir?
Yeah, now audible. Yeah.
Yes, sir. The question is, any precautions in hydrodissection in small pupil in case of soft cataract with adequate rexus?
Soft cataract,
Okay.
adequate access, and hydrodissection. You're asking. It's a small.
Precautions in
Yeah,
case
it's
of
a small,
hydrodissection.
soft cataract. We can hydrodelineate and pull it out. If it's a very soft cataract, say for example, it's only a PSC in a young patient, then what we can do is just hydrodelineate, and the soft nucleus itself can come up, and slowly in fact, sometimes with INA only we can remove the nucleus, or with very less.
Hydrodissection should not be done. Too much of fluid should not be used in these cases where the pupil is small. Otherwise,
Small.
you might have iris prolapse.
Prolapse.
And blindly don't do hydrodelineation or
Just below iris, don't go just without seeing that. You don't go and you don't do that hydrodelineation.
Have you ever done phacoemulsification in anterior chamber in these cases?
Yeah, that's what I think so. Now with the good amount of the viscoelastic substances, I think people have gone, and sometimes we have to do it. But according to the grade of the cataract, sir, we can do it.
Yeah. If it is not very hard, you can do it.
If it is not very hard, we can go for it. And
Yes.
putting every time good viscoelastic at each and every step, you can handle it.
Yes.
Or their antechamber maintainer as well. Any other questions do we have, Dr. Kritika?
No, sir, I cannot see any more questions. Either on none of the platforms, sir. They're done, sir.
Okay.
It's 9 o'clock,
Yes, sir.
and you can see the prime time now. Trump's problem is there, so you can see that also.
Thank you, Dr. Paresh sir, and Kamaljit sir, for giving your time, your valuable time to the iFocus, and for this lively and very informative discussion that we had, and lecture that we had on small people.
And thank you so much for repeatedly introducing me.
Thank you, Kamalji sir. Thank you very much.
Thank you, Dr. Vaidya. It was very nice talk, and we enjoyed it and learned a lot.
Thank you very much. So we are meeting for the first time, and I'm seeing you also for the first time. But I think so now we will repeatedly meet in our CFS meet or anytime whenever you meet.
Ankit would manage the meetings.
Sure.
Okay.
Thank you, Dr. Kritika. Thank you for the support.
Thank you, sir. Thank you for the wonderful class, wonderful presentation, and the video showing all of everything in one group. So thank you so much for the class.
Thank you, Dr. Amit, for handling.
Thank you, sir.
Thank you all. Thanks.